Hello everyone. This is the last um, video for chapter 15, infection and immunity. And I wanted to do this separately for immunization, just a little bit of line pieces left, and we continue with the last topic, which is immunization. So the last stage of Lyme disease occurs after weeks to months with neurological, cardiac, and joint manifestations. Neurological disease includes fluctuating fatigue, meningoenteritis, and or um, peripheral, central, or autonomic neuropathies. Cardiac disease includes myocarditis and heart block. Joint disease is more commonly reported in the USA and varies from these migratory arthritis to acute asymmetric monoarthritis and oligoarthritis of the large joints. Recurrent attacks of arthritis are common in 10% cases. Chronic erosive joint disease occurs months to years after the initial attack. Diagnosis is based on clinical and epidemiological features and serology. Serology will be negative in early disease and therefore not be helpful at presentation with erythema migrans. Seroconversion occurs 4 to 6 weeks following thick attachment. Isolation of the cancer is difficult and is not routinely undertaken. Treatment, the drug shows for early and completely Lyme disease is children aged 8 years or over is doxycycline and for younger children, amoxicillin, happily treatment with ceftriaxone is required for colitis or neurological disease. Nice and standards for conditions around investigation and treatment of Lyme disease in children. Now, immunization. Immunization saves millions of lives every year as well as preventing morbidity and disability and parents from taking time off work to look after their sick children. The most notable success of immunization has been the global eradication of smallpox in 1980. Polio has been eliminated globally other than in Afghanistan and Pakistan, and neonatal and maternal death remains in only 13 countries. Although through herd immunity, the whole population benefits by reducing pathogen exposure and vaccine measures. The vaccine coverage rates should these varies according to who the use of infection is. And the reproductive ratio of infection are over. And the number of individuals infected by one individual highly infectious disease such as measles, 12 to 18 individuals infected by one individual requires 95% vaccine coverage. For rubella, it is only 80%. Differences exist in the composition and scheduling of immunization programs. In different countries, schedules changes change as new vaccines become available. Developing new vaccine, incorporating them into national programs is a long and very expensive process involving not only development of the new vaccine, but large efficacy trials, licensing, organization of the implementation, consistent supply and safety monitoring. Financing is often another major issue. The process usually takes 3 to 10 years, though was greatly curtailed. The development and adoption of COVID-19 vaccines. The majority of vaccines are live attenuated vaccines, which are MMR, rotavirus, BCG modified organisms, inactivated vaccines that are inactivated polio, influenza, whole organs obtained by chemical or heat treated. These are heat treated and subunit vaccines, diphtheria, pneumococcal, HPV, Hep B contain antigens of the organs and usually require adjuvants. So live attenuated vaccines, MMR, rotavirus, BCG modified organisms. These are modified organisms. The other one are inactivated vaccines, which are IPV, influenza, whole organism obtained by chemical treatment subunit, which have just antigens of the organism, which is HPV, diphtheria, pneumococcal, and hepatitis B. The UK routine immunization program is already shown in the figure. Latest version is available. The rationale behind the current immunization, diphtheria infection causes local disease with primary inflammation affecting the nose, variants, lungs, or systemic disease, myocarditis, and natural manifestations. There were about 60,000 annual investigations, 3,000 deaths in the 1920s and 1930s, but immunization has practically eradicated this disease in the UK. Pertussis clinical features are described. Epidemics were associated with 60,000 to 160,000 cases each year in 74, the claims of an association between neurological conditions and pertussis vaccination rates fell and was followed by a large pertussis outbreak showing how epidemics can recur when immunizations rates fall. The safety concerns were not substantiated in subsequent studies, but a less reactogenic acellular AP vaccine replaced the whole cell vaccine immunization age was changed to an earlier age when fewer neurological conditions present. However, it took several years to restore confidence in the vaccine. In 2012, after a number of infants less than 3 months old died from pertussis in the UK, pertussis immunization from pregnant women was introduced to provide infants with muscle immunity prior to routine pertussis immunization. And universal type B, causing invasive disease primarily in the young children, with a number of reports of infection dropped dramatically after the introduction of avian influenza vaccine, but a gradual rise from 1988 occurred because protection was not maintained throughout childhood. This was addressed with an HIV catch-up program and to prevent a further recurrence, booster dose has been introduced at 12 months of age. Polio infection epidemics occurred in the 1940s, 1915, causes paralytic poliomyelitis in many children. Oral polio vaccine carried a small risk vaccine associated paralytic polio, about one case in 1.5 million diseases. Inactivated polio vaccine IPV is now used as it does not carry this risk. There were only 33 cases globally in 2018. Meningococcal immunization, meningococcal C disease was a major cause of meningitis in the late 1990s. The marked fall in the number of reports of group C disease in all age groups following the introduction of vaccine is shown. Invasive disease is now well controlled and has fallen to only 43 cases in 2018-2019. The number of cases meningococcal B has reduced since the introduction of the vaccine due to rise in meningococcal W disease across all age groups. ACWY conjugate vaccine was introduced for adolescents as they have a high rate of carriage. Reduction in carriage has resulted in gradual reduction of all cases of all ages. Measles savers an average 4 lakh notifications and 86 deaths annually in the 1950s and 1960s, both of which declined markedly following introduction of the measles vaccine. However, public confidence in the vaccine was severely damaged by huge media coverage of the assertion of a possible association between it and autism in a paper in the Lancet, although this has been discredited, vaccine uptake which fell and took some time to recover, although only 90% children are protected from prime vaccination with MMR at 8-12 months of age. Reduction of preschool booster MMR has reduced the proportion of susceptible school age children in measles in the 20. Although MMR coverage in England in 2019 was 95 for the first dose and 87 for the second dose, the number of measles notification in England and Wales increased to 981, mostly from Europe, and has resulted in the UK losing its WHO measles regulation status. MMR vaccine includes immunization against mumps, reduced vaccine coverage in the past has resulted in its free emergence young adults congenital well is now very rare. Pneumococcal vaccination increased into the UK immunization program in 2006. Prior to this, more than 500 children at 2 years of age developed invasive pneumococcal disease in Wales each year. To 2010, a 13 billion conjugate vaccine PCV effective against 13 excuse me, like there was 13 serotypes introduced which protects against about 90% of disease causing pneumococcal serotypes. Rotavirus vaccine has resulted in marked reduction in the number of acute gastroenteritis associated hospital admissions and reaction. Pneumococcal vaccine provides protection against the two strains, human papilloma 16 and pneumococcal virus 18, that causes 70% survival deaths. Initially given only to girls, but now also to boys as part of the in males, as well as anal cancer and head and neck cancer in both sexes. Influenza vaccine offered to young children as they are high risk of hospital admission than older children and an important source of infection as super spreaders. Limited effectiveness during some seasons and suboptimal intake. Hep B vaccine now given as part of the routine immunization schedule if mothers of hepatitis B surface antigen, HBs antigen positive. It is also given at birth, 1 month, 2 months, and 12 months of age. Babies born to highly infectious E antigen, HBe antigen positive mothers should additionally receive hepatitis B immunoglobulin at birth. BCG, bacillus calmette immunization in the UK is given the neonatal period and targeted to those at increased life and high-risk area. Variant of transmission born in high incidence country. The main value of BCG is in the prevention of disseminated disease, including meningitis in younger children, as a rationale for changing the time of vaccination from only during such a neonatal period, varicella vaccination live integrated varicella zoster virus vaccine is available and given routinely in some countries, but not in the UK. It will be given the siblings of at-risk children, those undergoing chemotherapy. The global immunization program routine childhood immunization provided for more than 116 million infants in 2018. Challenge to provide it for the remaining 20 million under vaccinated and unvaccinated children. There is also considerable concern about the disruption caused by the COVID-19 pandemic and that many children will not receive the scheduled vaccines. The contact duration vaccination should be postponed. The child has an acute illness, however, minor infection without fever or systemic, which is not a contraindication. Following vaccination, there may be swelling and discomfort at the injection site and a mild fever and malaise. Some vaccinations like MMR vaccine may be followed by fever and malaise 7 days to 10 days later. Live vaccines should not be given to children immunocompromised or in contact with a child on immunosuppressive therapy, except in children with HIV infection or ART in home. MMR vaccine can be given and advice should be obtained if the mother was on immunosuppressive therapy during pregnancy. A child who has had an anaphylactic reaction to vaccine should not be given a repeat dose. Rare adverse reactions which may not be identified during clinical trials need to be reported. For example, an association between a rotavirus vaccine and the increased risk of interception, which had not been identified on clinical trials, led to its replacement with safer vaccines. Local guidelines for vaccination and its contraindications should be followed. Vaccine confidence, increasing number of people who refuse to vaccinate their children, often referred to as vaccine hesitancy, has become a major problem globally. Reasons for this are complex. Some of these issues are many parents have never encountered any of the disease immunization schedules, reducing their concern about the severity of the disease, vaccine safety, concern about side effects, or the cause of the disease claim that MMR may be associated with autism generated huge risk of obesity, decline in vaccine uptake in many countries. Societies have become less tolerant of risk, believe the body is overwhelmed by vaccines, distrust of health services, formation of groups who are against specific vaccines or vaccines who journal through personal conviction, religion, culture, or socioeconomic issues and may use social media to generate fear. These highlight the need to improve engagement with the public to better understand and respond to their concern. Now, immunodeficiency may be primary and common genetic development effect of the immune system, genetically determined. Secondly, more common caused by breach of anatomical and physical barriers, burns, function, hyposplenism, and splenectomy, immunosuppressive or immune mediating drugs, antibody loss, nephrotic syndrome, malnutrition, HIV. Now, the primary immunodeficiency or the primary immunodeficiencies are rare. There are more than 250 genetically recognized disorders with new disorders continuing being identified. Most result from inherited effects in immune system development or function, and many are inherited associated to autosomal recessive disorders. There may be a family history of parental consanguinity and unexplained death, particularly in boys. The clinical presentation is highly variable, however, they should be considered in children. With spur infection, severe meningitis or peritonsillar sepsis persistent, does not improve with usual antibiotic, unusual venous system shy and Burkholderia sebaceous or recurrent appear to have resolved but reappeared. Family history of immunodeficiency following include chronic diarrhea and severe eczema from early infancy and additional presentation. The clinical presentation of the different primary immunodeficiencies is shown in investigation. This is directed towards the most likely cause and should not be more than initial testing of full blood count and differential of IG, MGA, and E, hemoglobin levels. And lymphocyte subsets will give a general indication of blood cell numbers and types and blood levels, and cherry test should be done if there is fortune growth, complement levels, if there is a history of opportunistic infection, positive infections of invasive, biogenic infection. Further investigation should be directed by an immunologist who can quantify the essential components of the immune system and also provide a functional assessment of immunocompetence. Genetic testing can reveal known single gene defects or novel diagnosis based on rapidly evolving exome and whole genome sequencing. Management options depend on underlying immune defect and can include antimicrobial prophylaxis for T cell and neutrophil effects or trimoxazole to prevent um, um, further investigation should be directed by immunologists who can quantify the essential components of the immune system and also provide a functional assessment of immunocompetence. Genetic testing can reveal known single gene defects or known diagnosis based on rapidly evolving exome and whole genetic sequencing. Management options depend on underlying immune defect and can include antibiotic prophylaxis and neutrophil defects which are trimoxazole when PCP and intraconazole are fluconazole to prevent other fungal infections. B-cell defect antibiotic prophylaxis azithromycin to prevent recurrent bacterial chest, ear, sinus infections. Antibiotic treatment from treatments of infections. Group choice of antibiotics to cover likely organisms. Generally longer courses with low threshold for IV therapy, screening for end-organ disease, CT chest scan in children with antibody deficiency to detect bronchitis and gluten replacement therapy for children with antibody deficiency can be given intravenously, which may require central venous, Portacat, or Hickman line presentation. Insertion of sub-Q bone marrow transplantation for severe combined immunodeficiency, chronic lymphomatous disease can be matched sibling donor, matched unrelated donor, or haploid identical parental transplant. Gene therapy currently an evolving area not widely available. Now, in the start, we had this is the vaccination chart. Immunization schedule in the UK from 2020. It's for 2, 3, 4 months. We give 6-in-1, which is diphtheria, tetanus, pertussis, polio, HIV, and DTaP, IPV, HIV, and Hep B is 6-in-1. And in 3 months, we give PCV, and in 1 year, we give PCV. Rotavirus is for 2nd and 3rd month, and meningococcal B vaccine is 2 months, 4 months, and 1 year. And then there's meningococcal group C, and it's in 14 years. ECWY, which is in adults. HIV and meningococcal C is given in 1 year, and measles MMR in 1 year, and then 3 years and 4 months. And there's a flu vaccine given 2 to 7 years, intranasal influenza vaccine annual 2 to 6 years, diphtheria, DTaP, and IPV is 4-in-1 and then 3 years and 4 months, and then human papillomavirus, boys and girls, 2 doses, 6 months apart, which is and 12 to 13 years in diphtheria, tetanus, TD, and IPV at the age of 14. years. This was given defect, T-cell defects, presentation examples, and severe and unusual viral fungal infection following growth in first months of life, severe bronchiolitis, diarrhea, oral thrush, neurocystic Jewisha pneumoniae, and disseminated or severe cytomegalovirus infection, severe combined SCID and heterogeneous stomatitis disorders were finally affected cellular immunity, fatal without treatment, HIV infection, dysphoric syndrome, triad of hormone deficiency, thrombocytopenia and eczema, X-linked Rijor syndrome, cardiac defects, palatal defects, abnormal feces, absence of thymus, hypoglycemia, and developmental delay, deletion of chromosome 22q11. Two, X-linked improperissivity disease, fungal disease, inability to generate a normal response to Epstein-Barr virus, either succumb with the initial infection with the second. It exerts atelectasia, defect in DNA repair, also increase the risk of lymphoma, cerebellar asphyxia, developmental delay, recent antibody defect in first 2 years beyond infancy because of passively acquired maternal antibodies, severe bacterial infections, 60 years, sinus, pulmonary skin infections, recurrent diarrhea, and fortunate foods, recurrent pneumonias can lead to bronchitis, recurrent ear infection, fluid, hearing, excellent withdrawn agammaglobulinemia, abnormal tyrosine kinase gene essential for B cell maturation, commonly variable immunity deficiency, CVID, B cell deficiency, high risk of autoimmune disorders, and malignancy, later onset than withdrawn agammaglobulinemia, hyper IgM syndrome, B cell produce IgM but are prevented from switching to IgG and IgA. Selective IgA deficiency, most common primary immune defect, usually asymptomatic or recurrent, ear, sinus, and pulmonary infection, neutrophil defect, recurrent bacterial infection of the skin, lymph, lung, liver, spleen, bone, pool, wound healing, perianal disease, and periodontal infections, invasive fungal infections such as aspergillosis, and diarrhea and faltering growth, granuloma from chronic inflammation. And chronic rheumatic disease, most are X-linked recessive. Some autosomal recessive neutrophil fail to produce peroxide after phagocytosis of microorganisms. And now it is, this was neutrophil defects. And then it was leukocyte function defects, delayed suppression of umbilical cord, delayed wound healing, and chronic skin ulcers and deep-seated infections, leukocyte LED deficiency neutrophils, surface adhesion molecules, CD15, leading to inability neutrophils migrate to sites of infection information, complement defects, recurrent bacterial infection, cellulite illness, recurrent meningococcal, pneumococcal, and hemophilus influenza infection, deficiency of complement components, early complement deficiency, terminal complement deficiency, and manners finding, and BL deficiency. These are clinical investigations to identify primary immune first line investigation, cellular immune defects with T cell, full count, lymphocyte, subset of CD3, total T cell, CD4, helper T cell, CD8 cytotoxics, and the antibody humoral ability of T cells to proliferate in response to nitrogens, the antibody humoral immunoglobulin levels, IgG subclasses, and so important to assessing antibody responses. Vaccine-induced antibody readiness pneumococcal lymphocyte subsets, says B cell level. Combined B cell investigation above, neutrophil specific genetic molecular tests for severe combined immunodeficiency, full blood count, assess neutrophil numbers, neutropenia, nitrobrood, tetrazoline test, abnormal in chronic rheumatic disease. Most laboratories now use newer assays to determine superoxide production and test for leukocyte adhesion deficiency, CD11, the CD18 expression test of chemotaxis, neutrophil mobility, and complement minus binding test of classical and alternative complement pathway, CH50 and AP50 assay is for individual complement proteins minus binding lectin levels, and addition test is HIV. So this is the end of the chapter. Thank you very much.